Thank you. Thanks for that kind introduction, Angela. Well, thanks, everyone. Thanks so much for joining today. Like Angela said, I'm a psychologist, but also director of research at the Menninger Clinic. And if you don't know the Menninger Clinic, we are just down the road in Texas Medical Center, but down the road, down Main Street, kind of at the intersection of Main Street and Post Oak. So we're inpatient, outpatient psychiatric hospital right here in Houston. And Google us if you don't know much about it. We are one of the top psychiatric hospitals in the country, and really just an amazing place to be. So I'm super excited, particularly to talk to you all today, because today's October 10th. And if you had a chance to look on social media, you may have seen today is World Mental Health Day. And so I really encourage you, scan that QR code, because it goes to the World Health Organization and lays out the plan for mental health across the globe. And what the priorities should be. So the tagline is, mental health is a universal human right. And the World Health Organization stands behind that. And this includes the right to available, accessible, acceptable, and good quality care. And it really relates to my talk today because I'm going to talk about what we can do to make care in intensive mental health settings even better. And it comes to, in my mind, and our mind at Menninger, comes down to increasing autonomy, people's decision-making and ability to have decisions made by themselves in their care, increasing the safety of these settings in intensive mental health care, and people's feeling of security, and then ultimately improving the outcomes. There is tremendous need to improve outcomes in intensive mental health care settings. So when we think about mental health care, oftentimes we just think about traditional outpatient care. So this could be medication management with a psychiatrist or psychotherapy with psychologists, social worker. However, there's a lot of different levels to this care, to mental health care. So these are just some of the levels, and you can put them in different orders based on who you talk to, but you have intensive outpatient settings, which can be 4 to 5 hours of psychotherapy, maybe infusion of medication management in that outpatient care. You can have partial or day hospitalization where you don't spend the night, but you're in the locked hospital during the day. You can have wraparound in-home care. You can have residential care, which means long-term mental health care, and then you can also have inpatient for more acute crises, stabilization. However, everyone shows the graph like this, and the levels of care like this, with connections between these levels of care. In reality, it looks like this. There are major gaps between all these different levels of care. And there are major drop-offs. You can go to inpatient, and then you have a discharge plan, but there's no one to carry that through. There's no one to carry you and support you, oftentimes, to go to the next level of care, whether that's your outpatient psychiatrist, outpatient psychologist, or a different kind of program, residential. And so you can have people get lost. And lost in these levels of care, it's confusing. It's confusing even for providers. Oftentimes as providers, we are emailing each other, who do you know for this? Who do you know for that? It's not straightforward. Today, I'm gonna talk about the highest level of care, inpatient. At Menninger, we have multiple units inpatient care with 120 beds. And in here, it is incredibly important that we focus on those three components of the treatment: increasing people's autonomy, doing everything we can to do that, their safety and feeling of security. Oftentimes, people can leave inpatient facilities and actually feel less safe, less secure. They can feel traumatized by their experience. And so there's tremendous potential for technology to improve that, and ultimately improve outcomes. And so I'm going to talk about one of the outcomes we care about the most oftentimes in inpatient, and that is suicide. People are very at high risk for suicide when they come to inpatient. However, so I have a question for the audience. Individuals are at highest risk for death by suicide at what point in their lives? Does anyone know? Have a guess? You don't have to know. I shouldn't say that. You don't have to know. When? 14? Is that what it was? Oh, at age 40. Oh, in the 40s? Older? Teenagers? It actually okay, that's more of a context. That's good. That's what I'm kind of getting towards. Good. I don't know who said that. I won't point you out. Well, what else? More of a context. Something that happens in someone's life. What? Yes, that's because I told you. Yeah. You ruined it. No, it's good. After inpatient psychiatric treatment. So not before someone enters inpatient psychiatry, not during, while they're there. It's after receiving our highest level of mental health treatment, someone is more likely to die by suicide. And to me, when I read that for the first time, and of course I've read it over and over and over again, I was shocked. I was appalled, being that we are an inpatient psychiatric facility, but also we feel a deep kind of ethical, moral obligation to change this. This is a terrible outcome. This is the worst outcome. We don't want people to be more likely to die, right? We want people to survive, and we want people to have a high quality of life. And so it's incredibly important that we measure it. So we've been really thinking about this problem. So Angela mentioned we have a lot of problems in inpatient psychiatry, and this is one of them that we've been really focused on. Death by suicide post-inpatient psychiatric hospitalization. So why might that happen? And we have some hypotheses, and they're based on data around sleep. So I'm going to kind of just lay out the issue from the beginning, and then I'm going to show you the data. What we find from our papers at the Menninger Clinic is that sleep really matters. And this is not just established by us and the work that we have done. This is well established in the literature. So sleep really matters and is foundational, like was explained by Angela at the beginning, for physical and mental health. So sleep really matters for mental health. Outpatient, inpatient. There are meta-analyses of RCTs that establish this. They say, sleep disturbance causes mental health problems. This is fact. Sleep really matters for mental health while inpatient. This is our contribution to the literature, is really understanding sleep and starting to really understand the link between sleep and mental health outcomes while someone is inpatient and post-discharge. And then this comes from our data and longitudinal data. So I love the trajectory analyses we saw from Dr. Buckley and Dr. Baker. And we've really done this, but within inpatient longitudinal data. So during someone's length of stay, thinking about how sleep relates to someone's mental health outcomes at discharge and post-discharge. And this started with a paper led by now Dr. Elizabeth Reyes. She was a research assistant in our lab who went on to graduate school in clinical psychology. And we found that with subjective, so this is subjective data, so this is self-reported sleep disturbance. Those that do not respond across their length of stay, so that red line up there, are more likely to have worse clinical outcomes, so mental health outcomes at discharge and post-discharge, including suicide risk. So this graph shows time in treatment, so their length of stay on inpatient, and then the sleep disturbance item from the PHQ-9, which if there's sleep research out there, I know that's not the greatest data, and so we changed that in our data, and we started to look at separate constructs in terms of sleep, looking at nighttime sleep quality and daytime sleepiness. Still separate construct, still subjective measures of sleep. And this, we find the same thing. Those that have high sleep disturbance throughout their length of stay, for nighttime sleep quality and daytime sleepiness. So you have poor nighttime sleep quality and it's really affecting you during the day. you have worse mental health outcomes at discharge. Anxiety, depression, emotion regulation problems are worse, and your suicide risk is higher. And so then we looked at this much more precisely in relationship to suicide risk, right? So if we know post-discharge from inpatient is the highest risk period for suicide, we really need to look at, okay, the relationship between these sleep variables, nighttime sleep quality, daytime sleepiness, and suicide risk, and see, are the things that we know that are associated with suicide risk, are those still predictors when we include daytime sleepiness and nighttime sleep quality in the model? Or kind of what happens when we include all of those variables? And so what we found is nighttime sleep quality, daytime sleepiness throughout someone's time in inpatient predicts suicide risk over and above everything else. Those factors listed here are the factors that we know are related to suicide risk that's well established in the literature. And they were across our models, but not as strongly as sleep problems. So sleep problems being nighttime sleep quality and daytime sleepiness. And remember, this is patient-reported nighttime sleep quality, daytime sleepiness. And so this is incredibly important because nighttime sleep quality, daytime sleepiness, those are often just kind of side examined, if not at all, during someone's length of stay. Instead, we rely on things like suicide attempt prior to admission, suicide ideation prior to admission, their sex. Males are more likely to die by suicide. So thinking of sleep over and above all these other variables, data now have shown us sleep is incredibly powerful. So our data show that sleep obviously really matters. It really matters for mental health. Really matters for mental health while inpatient. So this is for suicide risk as well as anxiety, depression, emotion regulation. When we talk about foundational, sleep is foundational for mental health. If you are not sleeping well, right, if you're falling asleep during the day, that daytime sleepiness, if you're falling asleep while you are inpatient, trying to engage in therapy or group sessions, and you can't stay awake, you're not going to be able to go through CBT or cognitive processing therapy for your trauma and process different events that have happened to you. You're not going to be awake. And so sleep really matters for mental health while inpatient and post-discharge. So our data have shown us that if you have sleep problems that are unresponsive to treatment as usual while inpatient, that you're higher risk for suicide post-discharge. So what we really think is good sleep for these patients would be life-saving. If you can get good sleep while you are inpatient, then it could actually save your life post-discharge and reduce that risk significantly. So it's helpful for us to lay out the problem, I guess, but more helpful if we can start to think of solutions. And so that's really what we have been working on now. And so we wrote 2 brief reports on just laying out some ideas around how we could improve sleep disturbance while inpatient. If we know sleep disruption is causally related to mental health outcomes, and now we have shown it is also specific to inpatient, we have to fix it. We have to change it. We have to have innovations. We have to leverage data to improve it. And so we have thought about some areas of doing this with wearable technology, but there's all sorts of people out there using infrared cameras, video. There's a lot of different kind of strengths and weaknesses of each modality. We focus on wearables, partly because our backgrounds are in signal processing and psychophysiology and sleep. And so what we have thought about in particular is that during inpatient, we are actually likely contributing significantly to sleep disruption of patients. And patients who come in with pre-existing mental health issues and sleep disturbance. So we know that from our work as well. So this figure here shows a process called a Q15 check. So on inpatient psychiatric units, hospitals, whether it's at the Menninger Clinic or it's at Ben Taub here in Houston or any other facility across the country, providers, clinicians, mental health technicians will do physical checks on someone to show and demonstrate and to record someone's safety and that they are not self-harming or and they're safe and alive. And so at Menninger, we do Q15 checks. Ben Taub, they do Q15 checks. Houston VA will do Q15, so these checks every 15 minutes. During the day, that's okay, right? Somebody's in a group room, and you see that they're in the group room, you record that they're safe. At night, what do you all think this looks like? How? Yes, and an anti-ligature wrist door, so it sounds like a gunshot. For us at Menninger, it sounds like a gunshot. It's really loud. Okay? What else? What would else be kind of disturb someone's sleep? Just picture someone coming into your room every 15 minutes while you try to go to sleep or sleep.
You're just waiting for it to happen.
Anticipation, right? The entire time. And then you think about somebody who's maybe experienced significant trauma in their life and maybe even significant trauma in their bed. And there's many, many layers to this situation. And then they're also trying to sleep. They're often very tired. And so there's not just, right, the sound, noise, right, noise in the hallway, noise of the person going in somebody's room to check on them. Patients will complain of like a nurse or mental health technician, they're breathing. Like at that point you can like hear someone breathe or like, clear their throat. And it's just, every noise and all these noises and also light coming in the room. If a nurse or technician can't see someone's face, they will take a flashlight and shine it in somebody's face. But these are well-intentioned protocols, right? These are well-intentioned. We don't have anything else to replace them. Unfortunately, though, someone can die by suicide, by asphyxiation, so by hanging is the most common method within inpatient, in 4 to 5 minutes, about 6 minutes. And so these Q15 checks actually are, don't quote me on this, for liability reasons, to demonstrate we're doing something, because they're actually ineffective in catching kind of these moments. You have unchecked windows of time, right? So all of these blocks, these white sections on this figure, are all unchecked windows where someone can, if they want, harm themselves. So we've thought about the relationship between sleep and suicide and these Q15 checks as a spiral, that they are likely, the sleep fragmentation is really compounding the effects on sleep outcomes and sleep disturbance throughout someone's length of stay. You have a 5 to 7 day length of stay, compounds for those days. At Menninger, we have 4 to 6 weeks. It compounds each time. If you don't sleep well one night, right, you also have sometimes even worse difficulty falling asleep the next night, and it really affects your mood and how you feel. And so we've thought about, can we reverse that with wearable technology, right? Wearable technology, actigraphy can really accurately predict whether you're sleeping or not. And so actually turning those unchecked windows of time into checked windows of time via a wearable derived vital sign. And this is something we've been working on a ton. And Jessa Westheimer has led our efforts in this and developed a model for really thinking about how do we develop technology for inpatient psychiatry. Inpatient psychiatry has had limited innovations in the last multiple decades. And so really thinking about how do we develop new technology for these settings. And so she took common software development frameworks and developed a time framework and collapsed some of these processes across here to really come up with a very specific framework for inpatient psychiatry. It could be generalized to other mental health innovations. The most important thing I want to point out to you is that there are two parallel processes here. It is not just the high-tech prototype, or you could think of AI up there, right, like a technology development. At the same time, there has to be a high-touch protocol. The clinical protocol has to be developed in parallel at the same time as any technology. Mental health end users, whether it's a clinician, patient, administrators, it is very difficult to get buy-in and to get individuals to change their processes in these settings. And so by including them, these stakeholders from the beginning, developing a protocol, a clinical protocol that makes sense is incredibly important, because otherwise at the end you do not have a software that's intuitive and one that does not have inherent buy-in. And so with that, these, especially in more intensive mental health settings, you then are going to have tremendous pushback. These are providers who are dealing with putting out fires every single day. They don't have the time and capacity and bandwidth to deal with putting out another fire with a software system. That's not going to be a priority at all. And so we've thought about how do we flip a common model of suicide assessment really to integrate wearables. So the aims, assess, intervene, monitor. And so we've really thought about, okay, can we flip that, put actually wearable monitoring in the middle? And there's opportunities for AI in here. I'm running out of time, so I'm gonna kind of go fast through these. Peter Jacobelli has led our software development, where we are taking wearables data and visualizing it in a meaningful way. But importantly, he works so closely with Jessa to involve stakeholders in this process. There have been multiple stages in developing this software and this interface where they have thought, well, that would be a really cool feature. This would be a really cool feature. Clinicians are like, absolutely not. Do not do that. Don't waste any time. We won't use it. It sounds cool, but it doesn't change anything to our workflow or our decision-making process. And so it's been invaluable. Looks very simple, but where he's pulling in real-time wearables-based data into here and to make decisions in the background, ultimately, that are visualized like this in a simple way, right? We are mental health clinicians, providers, oftentimes need, like what Justin was saying, really they want the snapshot, what to do, in a really concise way. And so this tells them what to do very quickly. So how can AI help? And these are just my thoughts. So AI obviously can be integrated, and I think really thinking about, if you specialize in AI, machine learning, how can AI be integrated? Obviously from the technical part for mental health applications, but then also not forgetting about the human part. That is incredibly important, right? Because you are dealing with humans with mental health issues. That can be significant anxiety, that can be psychosis that involves paranoia, maybe around AI and data sharing and what's happening. And so thinking about that human component. Can AI help reconnect these places? I think yes. There is tremendous amount of data. If you can pull it all together, and can we have better prediction of what level of care does someone need to go to, and then how to get there better, I think it can connect that. My goal today, hopefully, is that you could get excited about intensive mental health care settings and the opportunities there for AI. There is a tremendous amount of data. There are a tremendous amount of problems. And there's a lot of people who understand the data deeply, but they don't know how to apply AI and machine learning. So there's a lot of opportunity there. But also not forgetting, right? You're dealing with humans, and you're dealing with humans with psychiatric issues. There's also a lot of opportunity around what we're doing with the wearable-derived vital sign. There's a lot of opportunity to use AI and machine learning in this, but not forgetting, right, that AI, the prediction, whatever outcome is being predicted, has got to be clinically actionable. And that is determined by the people who are going to use it. That's not determined by us as the people who are developing it. If they tell us we're not going to use it, we say, okay, now what do we do? How do we change it? How do we iterate? That's a big part of that time model, iteration based on feedback. And then obviously there's opportunity for AI across this whole workflow. But also, I'm going to stress, don't forget the human component of it. And then just briefly, we have our wearables data is being sent to this interface, so that's clinically actionable. Another piece of it is we have the data in real time being sent to a database where AI could be learning and evolving in the background to build better predictions. Ultimately, our dream is that we could predict suicide risk outside the hospital. Could we hand somebody a wearable, for example, with their algorithm on there that predicts their suicide risk? And we have a safety plan in the wearable, and that maybe signals to whoever they have consented to intervene. And could we stop these post-discharge risk by suicide? So really thinking of that human protocol, of course. So just a couple takeaways. Today's World Mental Health Day, October 10th. So remember that. Mental health is a universal human right. Check that out. The right, and this includes the right to available, accessible, acceptable, and good quality care. And I put a question mark for all my AI examples. And I actually, after I did that, I was like, no, it has to be a statement. AI is needed. I think there's a lot of pushback around, kind of the ethics, the problems around AI. I also think there's a lot of opportunity, particularly where we have a lot of data and a lot of problems, and that is intensive mental health care settings. But you just can't forget about that human component in AI. That is incredibly important. Thinking and working with the stakeholders, clinicians, the patients, of course, those with lived experience. And then ultimately in these intensive mental health settings, really focusing on how we can increase people's autonomy, their decision-making power, their safety and security in these settings, reducing trauma, and improving outcomes. We shouldn't have post-discharge higher rates of suicide, and we shouldn't have that, and we should have people with high quality of life after they attend these settings, go to these settings. So this is our research department. We work with wonderful faculty and staff at the Menninger Clinic and at Baylor College of Medicine, and so proud of all of them. They work across sleep, substance use, and suicide, and our research staff as well. And just gonna highlight our SMRF program. If you know an undergrad who's interested in mental health and intensive mental health settings and research and outcomes, have them join us. These are our 2023 SMRFs, and it's partly sponsored by Rice, which we're incredibly grateful for, and my email address. Thank you.
I'm gonna save, okay, so I'm gonna do one question, and then we're gonna basically save rest questions for the panel.
First of all, thank you for your presentation. Just two quick questions, and they're related.
Okay.
First of all, how receptive are patients to the wearable technology? And related to that is, what kind of education do you have to do for IRB to have them approve wearable technologies for patients?
Yeah. So the IRB was very easy. There was no pushback from the IRB around wearables and inpatient. It was more from the clinical side. Clinical administration and ensuring the wearable was safe, particularly didn't have any detachable parts. Anything like that could be ingested, could be used for self-harm. So we had to use specific wearables, and we have to use specific wearables. And with patients, they love it. It actually brings them a little bit back to normal life. If they have a Fitbit at home or a Apple Watch, anything like that, then they get a wearable, and so they're very comfortable wearing it, right? It's just a watch, either an actigraph, and then we also use a Fitbit as well. And the one that we're developing now, we actually have developed an app, so it's completely locked down, with the exception of it's a working watch and also tells the time for them, so it helps orient them as well to the time and date, and then we're collecting data in real time off of it, off the back end. But patients have been very receptive.